Good afternoon, everyone. Welcome. I'm hoping you can hear me. Great. Good afternoon, everyone. Welcome, friends of the pantry. I see a lot of familiar faces, some new faces. I want to welcome you to the State of Hunger webinar. It's really exciting presentation today. I want to share with you some interesting partnerships and some of the work that we've been doing in conjunction with the Icahn School of Medicine at Mount Sinai. For those of you not familiar with me, I'm Stephen Grimaldi, the Executive Director of New York Common Pantry. Today's session is focused on something called nutrition insecurity. We're going to be talking about chronic diseases, food-related chronic diseases, and social determinants of health, and some of the things that many of you may be familiar with. For some, it may be new. So housekeeping before we start, please put any questions in the chat. We will try to answer as many questions as possible during the webinar. We'll send written answers after the webinar if we cannot get to every question. And for those of you who have joined us before, we do try to get to every question, as you know. So New York Common Pantry reduces hunger and promotes dignity, health, and self-sufficiency. We do this in a variety of ways and a variety of different programs. I encourage you to take a look at our website, nycommonpantry.org, to learn about the vast array of services that we provide to different populations. We're not just about food, we're also about healthy food. We're also about social services, nutrition, education, and meeting people where they are at, providing wraparound services to allow them to be stable and self-sufficient. I'm really proud to be joined today by Dr. Leora McGillner, Associate Professor of Pediatrics in the Division of General Pediatrics at Mount Sinai's Cohen Center for Pediatric Comprehensive Care. Leora and her teams work closely with NYCP to address nutrition security, and you'll be hearing from Dr. McGillner in a few minutes. So as we did last time, and I get often asked these questions, we did want to put a few definitions up today. We won't be going deep. I do encourage you to go again back to the website and look at our previous State of Hunger webinar, where you'll see we got a little deeper into this in previous sessions, as well as talking about the true cost of living report, which I think is very important and does frame some of the discussion for today. So food insecurity is defined as a lack of consistent access to enough food, whereas nutrition security focuses on well-being, prevention of disease, perhaps treating disease, right? There are many things, many different types of food that emergency feeding programs, food pantries, soup kitchens provide. And many of us in the field have really moved to addressing what we call nutrition security, providing access to healthy, fresh food. And providing a well-balanced meal as well. Last year, for example, we served 1.5 million pounds of fresh food. It's about 40% of our offering in our Choice Pantry program. Now, according to the USDA, more than 34 million people, including 9 million children, are considered food insecure. Of course, as we know, many will be also considered nutrition insecure. So those we serve at the pantry are both. And these are the challenges that we experienced many years ago when we took on a fresh food initiative and we decided we were going to think outside the box and not just provide some of the usual suspects as far as donated food goes, but that we were going to purchase our own food and procure food that was healthy and met our nutrition requirements. It's extremely difficult to eat well on a limited budget. More than 3 million New York City residents are considered income inadequate. We talked about that in the last webinar. They can't afford the basics. They include rent, food, healthcare, and childcare. Since the last webinar, I have some unfortunate news, and that is the U.S. Census released the latest poverty rates. The poverty among children has more than doubled, up to 12.4% compared to the record low of last year of 5.2%. I'm going to talk about why some of that has happened shortly. Now, more than half of New Yorkers earn less than $46,060 annually. That amount is actually 200% of the poverty level for a family of three. As you may recall, government benefits have an amount considered the poverty level, which determines eligibility for those benefits. If you make more than that, you're not eligible. So 46,000, while 200% of the poverty level for a family of three, it just goes to show that many of New Yorkers, including many who come to the pantry, including working households, need additional supports and may not be eligible for government benefits. Now, people struggle for a whole host of reasons. Food is obviously very expensive, especially at a time when we've seen record inflation. Even we thought we were out of the woods last year after the record inflation, but unfortunately, we saw a 3.6% increase in September. Childcare, housing in New York City, very expensive. We saw a reduction in pandemic-era SNAP benefit and increases in the number of people coming to our doors, but we're just unable to provide them with access to enough resources through the SNAP benefit just because of the reduction in that pandemic benefits, in those pandemic benefits. Changes in federal tax policies have also impacted the people we serve, the child tax credit and the earned income tax credits. The expiration of such have really devastated those we serve. Food-related chronic disease shortens life. It decreases quality of life, and children that have poor health don't learn as well. Adults aren't as productive and disproportionately use medical services. This is a huge problem for those we serve. And to help with this growing need, the New York Common Pantry offers programs and services to address hunger and poverty and income inadequacy through New York City. We provide free healthy food to families and individuals through our pantry, our Nourish program. We have farm shares, we have a soup kitchen, we have a brown bag program. We have case management services to assist our guests with accessing public benefits and resources, and we're going to talk more about that shortly. And of course, we have a Project Dignity program, which helps the homeless get showers, haircuts, and laundry. In 2023, we served 10.2 million meals. It's more than 667,000 guests. Now, as mentioned, we are pleased to have Dr. Leora McGillner with us today, the Associate Professor of Pediatrics in the Division of General Pediatrics at Mount Sinai's Cohen Center for Pediatric Comprehensive Care. Dr. McGillner, welcome, and thank you for joining us today.
Thank you so much, Stephen. It's really a pleasure to be here and talk about our partnership that we've been growing over the years. So just to give a little bit of background for those on the call who may not be familiar with the services that we offer at Mount Sinai, as Stephen mentioned, I'm a pediatrician in the Division of General Peds, and I work at what's called the Cohen Center for Pediatric Comprehensive Care at Mount Sinai. And it's basically the main pediatric practice at Mount Sinai's Uptown campus. And you can see some of the statistics. We do many well visits. We basically function as a very large practice for children ranging in age from 0 to 21. You can see the statistics. We have it just for the younger kids, and I'll tell you why after. But basically, about close to 90% of our patients are insured with Medicaid. The other 10% are either private insurance or self-pay. Our population is about 54% Hispanic, 40% non-Hispanic. We were about 35% African American, and 47% other race or mixed. I would say that about 86% of our patients speak English, 11%, I think that's Spanish, prefer Spanish or only speak Spanish, but many of our patients are bilingual. And you can see breakdown, as is true with many pediatric practices, we tend to see children a lot when they're young, have more well visits when they're younger. So about 63% of our visits are for children 0 to 2, and about a third, 37%, are for kids from 3 to 10 in this age range. So just to give a little bit of background, I'll just give a little bit of background more about our connection with the pantry. I learned about the pantry probably 10 or 15 years ago. We were finding growing rates of food insecurity amongst our patients. And I'm not even sure how I first happened upon the pantry, but we started meeting and talking and decided to collaborate on a few grants together where we could work on solutions to affect food insecurity in our patients. And we actually had a grant from the United Hospital Fund about 10 years ago, and we were really able to sit down at the table and figure out what's the best way to refer patients to the pantry. How can we give our patients the right information? What do they need when they go to the pantry? And that's really how we started. We also started as part of the orientation that our physicians have to their residency program. They take a tour of the neighborhood, and the New York Common Pantry has been one of our key stops during, before the pandemic. It was probably the highlight of our tour. And until the pandemic, we actually would do a service activity where we'd do sandwiches and pack packages. So we really ensured that our residents, our trainees in pediatrics, were learning about food insecurity, and we're learning about the solutions that are literally in our backyard to try to alleviate this problem. What happened was that during the pandemic, so we were working together, we were partnering, we would refer patients to the pantry. We had printouts, all the information. Where is the pantry? What do you need to get there? And we found that during the pandemic, the rates of food insecurity in our patient population skyrocketed. And we realized that we needed to do more for our patients. One of the things, and it just wasn't enough. And again, I'll say that the fact that the New York Common Pantry has a choice pantry where families can actually select what they want to get, and they have the ability to, see what's available, was a huge advantage for our patients. And we really wanted to figure out how we could capitalize on the relationship. So starting during the pandemic, we developed a partnership with the New York Common Pantry. And we actually, in addition to having the pantry, so we would refer families, and the pantry would contact the families and start the process rolling before they even go there. We also developed an on-site pantry where we would purchase food from the pantry, and we would be able to give families that first package right in the clinic. So just to give you, this slide shows the degree of food insecurity that we were seeing amongst our patient population. And as you can see, the rates are, and one of the tools that we've been using is the United States, the USDA 18-item food security screening tool, or a score. And as you can see, amongst our patients, at the time that we did this 18-item, we had about 13% that had high food security, 16% with marginal, and the rest had either low food security or very low food security. So this is pretty shocking to us. I mean, this was something that we knew, but I think it's really pretty shocking when you see this. In addition to not only, as I mentioned, okay, sorry, can go back for one more sec. That's okay. Okay. I was just going to say that another characteristic of the partnership was, as you'll learn more about, and as you've heard a little bit, the pantry would help our patients sign up for means-based programs, for entitlements, and other resources that we were not able to sign them up for. So helping sign up for SNAP, whether it's earned income tax credit, helping people in the shelter system, and really helping with all the other needs that our patients have. Okay, now we can go to the next slide. So, you've heard some, I'm sure you know some about this, but I think I can't underscore enough the fact that families, especially young children and pregnant women who don't have access to healthy food, are at risk of having poor nutrition and are at risk for overall poor health. And food insecurity has been associated in the long term with an increased risk of heart disease, diabetes, and obesity. I've had people say to me, well, how can that be that there's an increased risk of obesity when they don't have enough food? And I think, Stephen, you touched on it before when you talked about nutritional security, and the fact that people are not just having enough food, they're not having nutritious food. And we know that in the long run, it lowers life expectancy, poor nutrition security and food insecurity, and it definitely decreases quality of life. And not even to mention, which we'll talk more about after, mental health for children, developmental health, cognitive development, and overall quality of life. Next slide. Okay, so I just want to touch upon a term which you may or may not be familiar with called social determinants of health. And these are the conditions in the environments where we are born, we live, we work, we play. And these conditions affect a wide range of health, functioning, and quality of life outcomes. And some of these can be your socioeconomic status, your level of education. It can be the built environment, it can be whether you have access to parks, as well as your social support network. And it can obviously also be your degree of food security. And we know that social determinants of health have a huge impact on someone's physical health, mental health, quality of life, and particularly in pregnant women and in young children, it can really have a tremendous impact on a child's growth and their development. So this is really critical, and I think it's so important to underscore that connection between health and nutrition, and between getting good medical care and also having a well-balanced diet and access to healthy food. And I think it's, as a pediatrician, I think we need to address this at every age, but particularly with pregnant women and in that early childhood. I think that's when we really, really need to focus and ensure that we're laying a strong nutritional foundation and giving children everything they need to grow and thrive. So this, I know this slide is a little busy, but I just want to talk a little bit about a study that we're doing in conjunction with the York Common Pantry and the research that we're doing. So we got a grant a number of years ago in partnership with the York Common Pantry to actually study the impact of screening for food insecurity and referring those with food insecurity to the York Common Pantry, on providing them with food both at our site and then at the pantry, and providing families with resources. And as you can see here, we were doing a phone screener where we'd have our volunteers call families before the visit and I'd ascertain whether or not they had food insecurity, or we would do it on site. And then when we identified families with food insecurity, we were able to refer them, make a referral to the York Common Pantry. We were also able to give them information about WIC, SNAP, and other resources. And then in addition to screening for food insecurity, we were also screening for other unmet social needs and providing resources and referrals to community-based organizations as needed. And I think if you focus on the upper half, the referral to the York Common Pantry, initially, before we did our study, we had done another study, and we found that a large majority of the patients, where we would just give them a piece of paper and say, go to the pantry, a lot of them did not go. And one of the things we changed in this study was we actually, in partnership with the York Common Pantry, we provide the pantry, of course, with the patient's approval, the pantry gets the family's name and phone number, and they reach out to them, and they start the process. And what we found was that the rate of referral completion, here you can see the closed loop system. So basically, we see the patient, we determine whether or not they have food insecurity. Families who are so desirous are given an NYCP bag on site in our food pantry. We enter them into the common database, and then the case managers from York Common Pantry call the families, enroll them in the choice pantry, and do a whole intake and ascertain what other resources they are eligible for. And this is really, and then once they sign up, they are eligible to pick up their groceries biweekly. I will say that in addition to, I mentioned we were having people screen our families remotely or on site. We now just piloted about 2 months ago through MyChart, if some of you are familiar with that, but the patient portal, families are able to screen themselves prior to the visit using MyChart and actually request a referral to York Common Pantry, request a food package. So we're still going to be evaluating that process, but it's exciting for us because we're giving even more choice to families, and hopefully they're able to do it on their own time and in the privacy of their own homes. So I guess the other thing I was just going to say was that it's critical to us, as I mentioned, to ensure that we're screening everyone, that we're not making any judgments or decisions for families, and we're putting sort of the locus of control on them. And I think that's one of the reasons we're very excited about the MyChart screener, because this is giving families the opportunity to screen themselves. I think the closed loop system is really important because I think it really shows the partnership between our two, our what we would call like an academic community partnership. And I think it also is the culmination of a process that's taken years for us to hone, and that we're constantly refining and working on and trying to ensure that together, Mount Sinai and the New York Common Pantry, we're really trying to ensure that we're taking a holistic approach and we're providing the best level of care to the families that we're serving. So that's
Absolutely.
pretty much what I wanted to say about that. I can turn it back to you, Stephen.
Well, thank you. Thank you, Doctor. I think it's important to mention that when this closed loop system is absolutely essential for us to have this two-way communication. And I think that's the innovative piece, because our case managers come in, at the point when that referral comes into the shared database, and we call the families in that database, we enroll them via phone, right, in our choice pantry. Now, sometimes the process takes time. It can involve multiple phone calls. People are working, people are very busy. We do have case managers who speak Spanish, Cantonese, Mandarin. We have a staff on site who speak French as well. So we're able to communicate in people's preferred language. And once our case managers reach the family, they use that screening tool to determine how many people in the family are in need, what the needs are. We enroll the family by phone. As I mentioned, it makes it more likely that they will come in and pick up their pantry bags. That first package is very, very important. And I think that's really the way that that people see the food that we provide, and they're surprised perhaps by the quality of food. 40%, as I mentioned earlier, of our food is fresh produce. But in addition to fruits and vegetables, they receive proteins, grains, milk, and other shelf-stable items. Now, during the screening, the case managers also assess, again, if the family needs other needs-based services and benefits, as Dr. McGillner mentioned. We can assist them with applications for those programs. And so far, we've enrolled 135 families referred from Mount Sinai in our pantry, provided screening for public benefits and other areas where they just might need assistance. Speaking to some of our case managers and hearing stories, they shared a story of a woman named Celia. She was really apprehensive because she thought that taking pantry packages or applying for SNAP would really negatively impact her immigration situation. But we put her in touch with Free Immigration Law Service. And at that point, she was comfortable. She learned that she was, in fact, eligible. And our case management team enrolled her in the Choice Pantry. We assisted her with SNAP application. She got an emergency allotment. She gets regular recurring supports. And that's really life-changing, because folks who are constantly worried about what resources they have are playing triage with these various bills, and someone goes unfed. And oftentimes it's the parent, right? They're going to feed their family first. She's very, very appreciative that we're able to support her. She continues to come to pantry. Again, this is the closed loop system. So we circle it back. We're able to feed that information back to Mount Sinai and Dr. McGillner's team, and so that they can follow up with them thereafter. So it really is a system where we can both see the same information and then ultimately help the families the way they can best be served.
And just maybe I can add in, Stephen, that I did mention before the research study that we've been conducting, looking at the impact of the program on a number of factors. I mean, the most obvious one that we'll be looking at is the impact of the partnership on families' food insecurity. So what level of family food insecurity did they have at the outset, at baseline?
Right.
And then how does that change over time at 3-month interval and then at a 12-month interval? And we hope, we know it's very complicated. I think in the midst of beginning to collect data, rates of inflation went on the rise. We were still sort of in the after effects of the pandemic. So we know that it's multifactorial. There are a lot of factors that are going on here. but we really want to see if there is an impact of participation in this program on a family food insecurity. In addition, we also are looking at other outcomes, such as parental stress and worry, using some validating screening tools. How does having your physician, right, and their team address these needs? What does that do to a family's stress, their worry, their concern? What does it do to the way they feel connected to a practice? We're also looking at that. We would hope, our hypothesis would be that just having, whether it's your clinician, their team, the pantry, contacting you and asking how you are and trying to give you resources, we would hope that that would positively impact the level of stress and worry that families have. And finally, I think the gold, what we're really trying to find, that pot of gold, is health outcomes. What is the impact of participation in a program like this, and the impact of improving food insecurity on visits to the physician, immunization status, visits to an emergency room, exacerbation of chronic illnesses like asthma. So these are some of the things that we'll be looking at. I hope to have some more data that we could share perhaps on the next call. We do know from our preliminary data that we have a population that had many needs, and that was really very affected by the pandemic and by inflation, and really was very desirous of getting help. I will say, I'll just share a family that I've been taking care of with 4 kids. Actually, mom was pregnant with her 4th child and came to see me and literally went into labor with number 4 on a Tuesday night. And we actually, Alexis, who's the coordinator of our pantry, and I sat and played with the other 3 kids until dad could get there and take mom and meet mom so they could have their next child. But they were really experiencing food insecurity. And mom initially was reluctant, was not sure about becoming a client of the pantry. And what happened, over time, I saw her very often, especially with the new baby. And it was really hard, 4 kids now and a lot of stressors. And every time she came, we would offer her one of the food pantry bags that we had. I should mention also, in addition to the food bags, we also have emergency supplies for our patients. So diapers, wipes. We have a large population that's currently residing in shelters. So we've been trying to provide, as feasible, emergency supplies. And I think over time, we really built up the level of trust. And mom decided she wanted to become a client. And pantry reached out, and she's in the neighborhood. It's very convenient for her. I sort of describe it like, it's your own form of Fresh Direct. You get to pick what you want. And I think it's been tremendously helpful for this family, just alleviating some of the burden and some of the budget that they had to allocate towards food, they can now allocate for something else. So that really, and I bring up that story because it wasn't a one and done. I would just remind them, we have this available. Would you like this? And finally, mom, decided we had this level of trust. And I think, that also figured into the equation, and she became a pantry client, and they've been very happy since. So.
And it's very interesting because these are the sort of stories that we hear. Some people are reluctant, some people have ambivalence, some people don't know what's available, or they think there are strings attached, or there's stigma attached to go to some of these programs. And sometimes it does take, and as I mentioned earlier, some people are working, they've got so many things going on, but by ultimately visiting the space, and in this case, this innovative program of getting the package at the clinic, I do think it makes a huge difference. Dr. McGill, there's some questions coming up in the chat, and I know we want to get to some of those as we head towards the 45-minute mark here. How common is it for pediatric primary care clinics to integrate social determinants of health into their practice? And these kinds of community partnerships with organizations and these type of partnerships, if it's not common, which I don't believe it is, from the clinician's perspective, Dr. McGillner, what are the major challenges?
That's a great question. So actually, the American Academy of Pediatrics recommends that physicians screen families for social needs, and food insecurity is probably top of that list. And they also recommend that when feasible, incorporating programs or integrating programs into your practice that can address the needs identified is ideal. So I think that's aspirational for most places. Um, I would say many practices, particularly those of us in large city clinics or serving under-resourced areas, are screening for social determinants of health, for social needs, but it is definitely not, I would say it's still not in the majority of locations. A big part of this, I think many of us feel, you can't ask a question if you're not prepared to deal with the answer. So if you're going to ask someone if they're food insecure and you don't have a resource to give them, it's actually has the potential to make the problem worse. So I guess the answer to the question is, I still think it's not in the majority of practices. It is definitely best practice. It's recommended. I think having it integrated into your practice so that you screen and I also always tell my doctors, we don't want to make any judgments. I have been shocked sometimes where I see a family and I'm shocked that they're food insecure. They might even have private insurance and they have all these bills and all these things and they can't put food on the table. So that's why we call it screening. We don't cherry pick, we ask everyone. So that's one thing. And then we have to be prepared, whether it's referrals to our on-site pantry, to the New York Common Pantry. We give out lists of resources. We have families from all different boroughs. So we have links to databases of pantries in every borough, and we really try to do that. Challenges, as you can imagine, having staff to oversee this, to ensure that you're giving out the right information, that your information is up to date. I think almost as bad as not having information is giving out information that's wrong and giving people phone numbers to places where they don't pick up. So I think that's a huge challenge. And I also feel like we all need to advocate to our health systems, practices, clinics, to tell them how important this is. This is health, right? Assessing for food insecurity and for nutritional security has a tremendous impact on ultimate health outcomes. So it's one of these things, if you can prevent, if you can put in money on the front end, hopefully you'll save it on the back end.
And I think there are also so many ways that we have partnered the New York Common Pantry and Mount Sinai, and I think that these are low-cost solutions too. While I do think this particular innovative model really moves the dial on food insecurity, on nutrition insecurity, because again, there's this interconnection, this closed loop system, and also having a pantry on site. We do other things. I know we have the Food MD, a produce prescription program that's being piloted with Mount Sinai and 4 other clinics that we use. And it's really an interesting model where doctors write prescriptions. It's a different model. It's very similar, but they get a pantry package in addition to the special produce package. So we're looking at that as well. Again, another example of this, the partnership and taking many forms. We have a table at the Mount Sinai Green Market to offer online nutrition education classes. We do that. We allow people we take them on tours. They get Mount Sinai bucks, health bucks to be able to utilize at that market. And that's a really special relationship. And because we have these online classes, then they're referred to those classes and they can not only learn about the food and the different types of produce, perhaps that they may not be as familiar with, but how to prepare it through that. So there's another aspect of it, of the partnership. Dr. McGillner, I know we have other questions. I know you mentioned earlier about the residents coming to learn. It's something that we're very, very proud of, being able to have that connection. I would just again like to highlight that for our listeners. I think it's so special. Residents come, they will learn about food insecurity, not only how to identify it, but what we do. And I think it's really helpful because, like you said, it's one thing to have a screening tool. It's another thing to have an answer to respond to that screening tool. So I do think for those out there who do this work, that's a really important part of the integration between the two entities.
Yeah, I was just going to say, I think having our residents, I can talk till I'm blue in the face, but bringing our residents to the pantry, having them see, having them speak with your staff. And, it's amazing because I guess we have representatives from different programs who talk about what they do. And it really, I know that residents will say this is one of the highlights of their orientation. And if they want to come back again, they're able to. I think it's been a really important part of their education. I'd also mention that the Mount Sinai Medical School EHOP clinic, which is the student-run free clinic, also refers patients to the New York Common Pantry, just as another example. And I do know that nurses at Sinai and actually physicians and colleagues have done fundraisers and have had, whether it's for their children's bar mitzvahs or other events to raise money for the pantry, which I think is incredible.
Absolutely, yes. There've been those fundraising opportunities that I believe that have happened with nurses and doctors, and we're just really grateful for that support. But I think it also gets to an interesting point, and I think we'll kind of wrap and end with this thought, and I'll tell you a little bit about other ways that you can help. But we can innovate, we can have these great ideas, and we can develop best practices, and we learn from our great peers about these best practices. If the resources aren't there, like the grant that you received, Dr. McGillner, to do this work, if that wasn't there, it's suffice to say, this may not exist, right? Where would the resources come from? And this is a really important part. Innovation doesn't happen in a vacuum, a whole host of reasons, but it happens because there are resources. So a very, very important part. And when people ask, how can you help? You can spread the word about these sort of partnerships. You can spread the word about food insecurity, about nutrition insecurity. Come to volunteer. See us in action at the New York Common Pantry. Consider making a donation. We purchase nearly 70% of our food, and the need continues to increase. 32% rise in the number of individuals that we served last year over the previous year. And that number continues to go up as we've seen new populations come to our doors. You can start a drive in your communities, at your clinics, at your workplace, in your faith-based institution. By all means, you can do that. We have plenty of resources online to help you do that. Important that you think about ways that we can continue to do this work. At NYCP, we've expanded to better serve the community as a result of many, many years of learning about how to do this. We have 188 food distribution points throughout the city. We have a hub and spoke model, and we have a new food storage and distribution hub, which allows us to get that food out to those communities. Centralizing our food distribution, it will help us save costs, roughly 20 to 25% costs, almost double the number of meals that we can provide. It's a vessel for doing more. So we're raising money for this facility's upgrades. I would be remiss if I didn't mention that, that is a huge part of what will happen in the coming years as we address more nutrition insecurity. I want to thank everyone for their time. I want to thank you, Dr. McGillner, for all that you do for the community, for those that you serve, and for sharing your expertise with us today. So thank you.